Good afternoon, everyone. My name is Beth Gauthier, and I work in the principal's office. It is my pleasure today to be your host for this online town hall for Queen's faculty and staff. To begin, let us acknowledge that Queen's is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. I am grateful to live as an uninvited guest upon the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation. To acknowledge this traditional territory is to recognize its longer history, one predating the establishment of the earliest European colonies. And it is also to acknowledge this territory's significance for the Indigenous peoples who lived and continue to live upon it, and whose practices and spiritualities were tied to the land and continue to develop in relationship to the territory and its other inhabitants today. In a moment, we'll be joined by Principal Patrick Deane, who will be answering as many of your questions as possible in the next hour, along with Dr. Gerald Evans, who is the Chair of Division of Infectious Diseases, Professor of Medicine, Biomedical and Molecular Sciences, and Pathology and Molecular Medicine, and who is also a Medical Director, Infection Prevention and Control at Kingston Health Sciences Centre. I will also mention that today at Queen's, we've had a number of network issues that were causing some connectivity problems. We've been assured through ITS that that's been fixed, but we're going to keep our fingers crossed that that's going to continue for the next hour. However, you should know that we will be recording today's session and we'll be posting it on the principal's website later today or tomorrow, barring no other network problems. I would like to welcome Nathan Brinklow, Professor, Languages, Literature, and Culture, who will open our meeting today with the words before all else. Nathan?
Ja, Mary Beth, jag kunde höra att det var jag till lördag. Tänkte hans ni vaxnodom, wagenjatton, den kan jag haga ni wakwansodom. Det kan höra att ni Principal Deane, Donna Mary Beth, si wakungar och everyone hodungo o ni serdade. My name is Nathan Brinklow. I'm Turtle Clan Mohawk from the Tyendinaga Mohawk Territory, the interim associate department head in LSU for Indigenous Studies, and I teach our language here at Queen's. I'd like to thank both Mary Beth and Principal Deane for the invitation to join you today and share a few words as we open this gathering. In our way, being thankful is our first responsibility as people, and so we open and close important business by sending our greetings and thanks to all the entities and elements of the natural world that continue to support our lives. In these COVID times, we are all the more cognizant of these supports as we continue navigating difficult new realities. In recognizing these relationships and relations, we bring our minds together as one to accomplish our business in a good way. So we usually do this in our language, in Ganyakeha, since all those elements and entities obviously understand Mohawk. But for the benefit of those of you who don't yet speak Mohawk, I'll open in English and come back briefly at the end and close our business in Mohawk. And so now, as we begin our time together, we bring our minds together as one to send our greetings, our thanks, our love and respect to all the people, those of us on this call, those of us who weren't able to join us, and people everywhere who continue to work for good. We send our greetings and thanks to our First Mother, the Earth, as she continues to give up of her own strength and her own resources in support of our lives. We turn our minds to the waters and we send them our greetings as they continue to flow in their courses, and we send our greetings and thanks to all the plants that continue to grow and support our lives, the roots, the grasses, the medicines, the fruits, the berries, and all the trees. We send our greetings to the animal life that we see here and there as they continue to follow their original instructions. We look skyward, turn our thoughts to all the natural powers, the winds, the thunders, the moon, the sun, and the stars, as they're spread about the sky. And we send them our greetings, our love, our thanks, our honor, and our respect as they continue to do their work. And we send our greetings and thanks to Sungwe, the great strength of the natural world that we're still able to live in this place, even though we don't always treat it with the respect that it deserves. And so now we have sent our greetings and thanks. We have brought our minds together as one, and I've opened this business in the way that I've been taught. If there's anything I have forgotten to acknowledge or anything particularly important to you today, you are welcome to call that to your own mind as we continue. Thank you for your time and attention. Now, Mary Beth.
Thank you, Nathan. So if you have a question for during today's event for Principal Deane, Dr. Evans, or anyone else on our panel today, please enter it in the Q&A chat, and we'll do our best to get to as many of your questions as possible. So, Principal Deane, would you like to give a few opening remarks?
Good. Thank you very much, Mary Beth. Good afternoon, everyone. Very pleased you're able to join us this afternoon. And actually very pleased to be able to talk to you in person for the first time this fall. It's in my mind to say I hope you had a good restorative summer and have been able to return to the fall's activities somewhat refreshed. I recognize these have been extremely difficult times for every member of our community. And while I think Queen's has done extraordinarily well in the circumstances, I'm very much aware of the personal cost to all of you at which that has come. So I will say thank you very much for that, and hope you're all well. The other thing I would say is thank you very much for all the efforts to get us up and running this fall in person. It was an ambitious goal for the university to seek to achieve that. And I think things are moving well. So many thanks to you for your efforts in that regard. You need only look at our vaccination statistics and declarations to see that the community has really embraced, our university community has really embraced the opportunity to be back in person. I can share with you the latest stats, which are from Friday afternoon at 3:30. We have had 36,488 declarations of status, and they break down in a very positive and encouraging way. The employees of Queen's University fully vaccinated at 96.49%, partially vaccinated at 2.41%, which puts us at 99% either vaccinated or partially vaccinated, and only 1.1% not vaccinated or not yet vaccinated. So those are the employees. If you then look at our students, we've 25,931 of them fully vaccinated, which comes out at 95.58%, and then partially vaccinated another 3.32. So we're edging up towards 99%. Now, obviously, these statistics are somewhat complex because you have to make sure that the denominator is accurate, but we're very encouraged by these statistics, which continue to increase. So thank you to our whole community for that high level of commitment to resuming activity on campus as safely as possible. I'll just end, Mary Beth. I have acknowledged the strain that our whole community has been under over now well over 18 months. All of this has come at great cost, as I say, and there are plenty of unknowns ahead of us. So I appeal to everyone to be patient, to take to heart Nathan's advice to us, to support each other and to work together, because we have come a long way in addressing COVID in our university community. And although one is seeing light at the end of this, there is still quite a bit of work to be done. So thanks, Mary Beth. Look forward to hearing people's questions and to having our colleagues address some of them along with me.
While we were streaming the principal's town hall the other day, we unfortunately had a technical error that caused the feed to stop for everyone during Dr. Evans' presentation, and it could not be restarted. So we've decided to reconvene the town hall panel and record Dr. Evans' presentation again, and invite Patrick and other senior leaders to answer the questions that were entered in the Q&A chat before the event ended. We've retained the opening remarks from the principal from the original town hall, so I've included that in this recording and have allowed Dr. Evans to deliver his full presentation uninterrupted. I want to thank you all for your understanding and patience, and now I'd like to welcome back Dr. Gerald Evans to give his presentation.
Great, thank you very much, Mary Beth. So I'm going to just put my slides up here, and we'll take it from the top, as they say in showbiz, and go back into this presentation and hopefully help to explain a few things. So as many of you recall, we started off with this nice elegant picture of SARS-CoV-2, the virus that causes COVID-19, and which is why we're actually having this town hall today to sort of help deal with questions that may be out there in the wider university community. So my talk is going to cover sort of where we are today, do a little bit about the Delta variant, which of course I think everyone's very well aware of, has created many of our current issues in through the late summer and into the fall. Talk a bit about vaccine science and how it relates to Delta, and then I'm going to finish off by going through some issues around the coming fall and sort of tell you where we think things may be going. So I'm just going to get my laser pointer out here, as I've learned how to do these talks before over the virtual platforms. So as of September 24th, things in the province of Ontario were looking actually pretty good. Our effective reproductive number, that is the number of cases, new cases produced from any one case in a susceptible population, was actually below 1, which is very good, and it was at 0.87. We are still hovering around 600 new cases per day on average, with that starting to slowly decline. And right now, hospital occupancy and ICU occupancy within the healthcare system is at numbers which are, up a little, but certainly not in any red zone. So you can see they're color coded here as orange and yellow. Very good news is the percentage of the population in Ontario that's vaccinated. And amongst eligible people over the age of 12, we have over 80% now fully vaccinated, and almost 86% with 1 dose in, which is really important because we know that people who've had 1 dose oftentimes will have a second dose over 95% of the time. So that's probably where we're heading to in Ontario as we wait and continue to see a rise in vaccines. So this is a graph of Ontario active cases. You can see going back to March, this was the 3rd wave during the spring that we saw, and that dropped off through the month of July. But since August, it has risen again. And a lot of that was related to what we now recognize as increased mobility amongst people as they were visiting friends and family over the summer months. And that led to a little bit more social contacts, which drove up cases across the province. But as you can see, this is not rising. This is pretty flat, and is certainly not having the typical exponential curves that we saw with previous waves of COVID-19. It's also reflected in what we see as a 7-day rolling average of new cases per day. And you can see here that that's flattened out very nicely. And we're sort of sitting around 600 and a handful of new cases per day. And that continues to be a good sign that we're not seeing this exponential rise in cases. You can look at it a little bit more closely if you change your y-axis here to go with between 600 and 800, and you can see that through the middle part of September, now into later parts of September, this 7-day running average is actually dropping. And so we're down at around, 621. It was the last one. This is a little bit of an older graph from a day or two previously. We can also look at test positivity. That is the number of tests that we do that are positive for COVID. You can see here during the 3rd wave, rates were very high in the province, which you can see in red here. In green, you're actually seeing what the test positivity was here in southeastern Ontario, which we track fairly closely. And so you can see at 10% test positivity, you're into a major wave. And what's happened here is we've had a rise in test positivity in the province in general, but it's kind of plateaued. And in fact is dropping a bit. Here in Eastern Ontario, we'd like to be below 1%, and we're close there, but we've had a little bit of blips related to some outbreaks that occurred through August and into September in the Hastings Prince Edward County Public Health Unit. A number below 5% is very good, because at about 5%, you start to see that exponential rise. If we look at that effective reproductive number, I already commented on this before, but this is it in graphic form. At 1, you're getting 1 new case produced from every case that you have. And so anything below 1 is good, anything above 1 is not good. And here you can see what amounted to the 2nd and the 3rd wave. And you can see a rise here quite precipitously, mostly from Delta, that started in the summer, but it's very quickly fallen down and is now well below 1, which is good, because that means we will not see, at the moment at least, a rise in cases. If we look at the southeast, where we are here in Kingston, we have seen a major drop through the month of July, and then in August we saw this jump, and this was related to some, again, socialization increases and some outbreaks that were occurring in some jurisdictions in the southeast, and we're now hovering sort of about 85 to 90 cases. If we focus in specifically on what's been happening in the last few months, we can narrow it down and look at the 3 health units here in the southeast part of Ontario, KFLA, Hastings Prince Edward, and Lanark Leeds Grenville. And you can see here by color coding that, again, most of the cases seem to be in Hastings, Prince Edward, although KFLA has had a rise now seen in some cases. But Lanark, Leeds, Grenville has much lower numbers, and that's probably related to the fact that they have a very much higher vaccination rate even than KFLA and Hastings, Prince Edward, which have very good vaccination rates. So vaccine is clearly important. So let's talk a little bit about the Delta variant. This is just a little schematic showing you the outlay of the spike protein and the ACE2 receptor and where these mutations are occurring. In a country where this t-shirt is worn by some people, you can see this sort of a cartoon showing what Delta really thinks about this, and of course has created enormous problems for our neighbors in the south. One thing to start off by pointing out is that the symptoms of Delta variant infection are really not any different from other variants. The predominant ones we see, which have some degree of specificity, are fever, cough, shortness of breath, and of course this loss of taste or smell, which has been well described. In children, GI symptoms can also appear. And in older adults, you may see a lot of sort of what we call systemic symptoms like tiredness, lethargy, malaise, and of course, myalgias and arthralgias, aches and pains in the bones and joints, which are common and very commonly with fever. But Delta really looks like the other variants that we've seen in terms of symptoms. So what do we know about Delta variant in general? So this is a great schematic that came out of Public Health England, where they were encountering Delta first and a little bit sooner than we did. And so they looked at really 4 factors, which was transmissibility, infection severity, immunity after natural infection, and vaccines. And what you can see here is that they've got evidence along all these lines, some with high confidence in that it's more transmissible, and high confidence that vaccines are going to continue to be effective against Delta, excuse me, and a little bit of low confidence in terms of infection severity and the immunity after natural infection, although we think that happens. And severity I'm going to comment on in a second when I show you some graphs that indicate that really the risk of severity here is related to hospitalizations, which are increased with Delta, but maybe not so much mortality or case fatality rates. If we look at this little schematic, which sort of takes us back to the beginning of the pandemic, over time along the x-axis here, this is the relative increase in reproductive number when compared with the original variants that came out, and the size of these circles represents the number of cases. And what you can see here is that some of the other variants, this is beta, this is gamma, actually produce smaller numbers of cases than what we saw with alpha and with delta. And with Delta, we can see large numbers of cases and the highest increase in the reproductive number as compared with the other variants. So, excuse me, Delta continues to be, our major issue at the moment, and it certainly is the variant that showed us the most increase in transmissibility. That can also be looked at in this sort of infographic, which sort of shows what the original reproductive number was for the virus that first emerged in Wuhan, China, the variant that eventually emerged out into Europe. And I would say here in Ontario, we are a group here at Queen's actually has done some work looking at D641G penetration into Ontario, southeastern Ontario. We saw this sort of relative increase from 2 to 3. And then with Alpha, we saw this increase as well in the reproductive number up to about 4 to 5. And with Delta, a fairly broad range, we're now a little bit more confident that it's probably about 6 or 7. And so this is the change we've seen in that transmissibility element. Interestingly enough, Alpha and Delta changed their ability to be more transmissible through 2 completely different cellular mechanisms, which we won't talk about today, but I'm sure I can share with people in the future. If we now look at Ontario and what happened going back to the latter month of 2020 through this calendar year, is early on into January and even into February, we were mostly seeing this typical D614G mutant, which had first come to Europe and to North America. But very quickly, in early spring, we saw the domination now of Alpha as it spread around the globe. And Alpha being more transmissible basically reduced the wild type virus down to very minimal levels. And then Alpha, by the time May and June rolled around, Alpha began to lose its dominance and it became Delta. And so these two orange areas represent two different things. This is the original wild type strain. This is the Delta strain. They're both characterized by having a lack of these mutations, whereas Alpha had both of those mutations very typically. So you can kind of see the way a virus variant comes in and sort of moves the other one out. Can also demonstrate it by looking at whole genome sequencing, which we do here in the province. And again, our laboratory here at Kingston Health Sciences Centre is one of 4 laboratories that's doing whole genome sequencing. Alpha is in blue, Delta is in yellow. You can see very quickly here that by the early part of May, when Delta first came into Ontario, it quickly dominated things, so that out here, and this is actually looking at specimens out to September 4th, Delta now dominates. Alpha has just about been wiped out. Gamma and Delta, and even some of the ones like Mu, were completely unable to compete with Delta. And Delta is now the dominant variant that we're seeing both worldwide and especially right here in the province of Ontario and in Canada. So here's a little bit of the data that we looked at that suggested that Delta might be a little bit more severe. And what they used here was the surrogate marker of hospital admission. So the idea was if you were admitted to hospital, you must have more severe disease than someone who isn't. And what they saw in Britain was when you compared Alpha and Delta, there was anywhere from a 1.5 to 2.25 times increased risk of hospital admission or emergency care attendance with the Delta variant when compared to the Alpha variant. So that told us a little bit about that sort of idea of more severity, because it seemed to be that people needed to go into hospital more frequently. When we looked at it, though, when it came to fatality rates, we saw a little bit of a different story. So there's 2 graphs here, again from the UK. These are people under age 60 in different age groups. The larger bold one you see here is 45 to 59. This is people over 60. And what they did not see was actually an increase in case fatality rate, but that may be somewhat confounded by the fact that, of course, Britain was very strongly vaccinating and quickly vaccinating older individuals over the age of 16, and in particular, very old people. I hesitate to say that at 60 and older, because that would include me in there. But essentially, what we saw was probably somewhat attenuated by the fact that the vaccines are effective against Delta. So the case fatality rate didn't rise, but that may be confounded by the fact that vaccine offers an enormous amount of protection from dying of COVID. So let's talk about vaccines and Delta. This is a really great slide. I love to use this. It came from the Financial Times, but essentially what it looks at is the age of an individual across the sort of x-axis here, and the y-axis is a logarithmic scale of mortality or lethality. So this is a 1 in 100 risk of dying. This is 1 in 1,000. This is 1 in 10,000, 1 in 100,000. And what you can see is the principal thing that determines death from COVID-19 is age. If you are older, you are more likely to die than if you are younger. This only goes down to age 30. If we continued it into childhood, you'd see even lower rates. But what it nicely, elegantly shows is that when you're vaccinated at any particular age group, this blue arrow represents the reduction in the likelihood of dying that's conferred by full vaccination. So that if you look at an 80-year-old with a risk of dying of about 1 in 100, when they're fully vaccinated, the risk of dying is down to 1 in 2,000. And that kind of puts them right about at the same level that you would see in a 50-year-old person who's unvaccinated. So this is really showing you very powerfully the effects of reduction in mortality when you're fully vaccinated. So how are we doing in Ontario? So this is not too complex a graph. The orange line is really just the numbers of vaccines administered daily, which you can see over here. And of course, we peaked in late June, early July, and it's been dropping off since then, mainly because we did a very aggressive vaccine campaign. The blue line is people who have received 1 dose. Purple is people who received 2 doses. So you can see our 2-dose administration is getting very close to our 1-dose administration. So we're doing very well. And I would say Ontario in particular has been an exceptional province when it comes to vaccine rollout, considering we're the most populated province in Canada. If we look at what's happening right here in KFLA in the Kingston, Frontenac, Lennox and Addington Public Health Unit, we have full vaccination in over 80% of individuals. And right now about 86.8 people if you include 1-dose individuals. So that's probably where we're going to end up unless we continue to push vaccines. So again, most people who've had 1 dose will get a 2nd dose. So we're going to be getting fairly close to 90, which is the kind of target that I think a lot of us have looked at. So how effective are vaccines against Delta? Well, when you compare them to Alpha, although there's a statistically significant difference, this is not clinically significant. And this is the Pfizer vaccine. This is the AstraZeneca vaccine. And you can see here the alpha variant effectiveness in blue, the delta in purple. And these are very high effectiveness rates. If you look at Pfizer daily dosing, we're looking at efficacy still of about 85 to 90% versus 90 to 93% that you saw against alpha. So although delta is a more transmissible variant, it is not more resistant to the vaccine, and our vaccines are effective against delta. I'm going to put this up too to show people that really there's no essential difference between the two current mRNA vaccines that are available here in Canada. There's Moderna, there's Pfizer. And this is just a graph from American data looking at double vaccination and antibody concentrations. And what you can see is that Pfizer and Moderna basically produce antibody concentrations that are not statistically significantly different. And for that matter, neither does Janssen, the Janssen vaccine, Johnson & Johnson, even though that's a one-dose vaccine, probably needs 2 doses. So Moderna and Pfizer are really equal. They're both equally effective. And can be literally interchanged with each other if necessary. This is a graph which is a little bit complicated, but I'll just run through it quickly. This is looking at 2 issues. It's vaccine efficacy against severe disease in the y-axis on all these graphs, and the x-axis is the vaccine efficacy against even getting infected. So if those are equal, they would fall along this line. So anything above that line favors the idea that vaccine effectiveness against severe disease is even higher than you see against infection. But what you can see here with the mRNA vaccines is we're looking at very, very effective prevention of infection and reduction of severity of disease. And even the vector vaccines like AstraZeneca and Johnson & Johnson show excellent protection against severe disease, perhaps a little bit slightly less against infection in general, but still very high at about 75%. Recognize that these graphs start at 50, not at 0. And here is another comparison of alpha and delta. Again, both of them above the line, suggesting very good, if not excellent, efficacy against severe infection and dying, but also very good effects against actually getting infected. So let's move on and look at what we've seen here in Ontario. This is a graph that I took off the Twitter feed of Bill Como, who's a statistician who I follow, and he maps out these things very nice, produces graphs. So what you see in red here are unvaccinated individuals, in orange are partially vaccinated individuals, and in green, fully vaccinated individuals. And you can see here as a measure of weekly cases per 100,000 population, the risk of getting COVID is somewhere around 70 per 100,000 in unvaccinated individuals, about 34 per 100,000 in partially vaccinated individuals, and really down at around 10 to 11 for people who are fully vaccinated. So there is an enormous benefit to vaccination when we look at just sheer case numbers in general. If we look at other things like being in hospital or being in an ICU here in Ontario, this is data from our science table, you can see that in comparison to unvaccinated people in orange versus fully vaccinated people, there are tremendous benefits to a reduction of people who are in hospital if you're fully vaccinated, and a marked reduction getting in ICU if you're fully vaccinated. This is just over time here, you can see on the bottom lines. But again, vaccination offers an enormous benefit. It's so beneficial in ICU, you can't even barely see the line at the bottom here. I want to comment on 2 things which really were a lot of the dominant conversation back in the late winter, early spring. One was, what about this longer interval? So in the clinical trials, Pfizer was 3 weeks apart for the 2 doses, Moderna was 4 weeks apart, and people were really worried if we went with a longer interval. But I want to show you here that the longer interval panned out to be the right answer. And this is actually looking at Delta virus infection, comparing people who got a 3 to 4 week interval to people who got a longer interval of more than 8 weeks. This is actually a bunch of healthcare workers, and these are measures of the antibody titers. And you can see here that they were actually much higher in people who had a longer interval between their first and second dose than those who had the first interval. And again, a lot of us who know about vaccine science were saying this is the right strategy, and indeed this has been borne out in this study as well as a number of other studies. The other question that always came up too was, what if I got AstraZeneca first and then I got Pfizer or Moderna second, what we call heterologous vaccination using 2 different platforms? Well, if you look at this data again from the UK, where they did study, specifically to gather subjects, I draw your attention. This is the alpha variant, and I want you to compare where the antibody titers are in people who got, for instance, 2 doses of AstraZeneca, and compare them to a person who got AstraZeneca first and Pfizer second. And you can see this dramatic increase in the reciprocal titer of antibodies that were present. So it pans out, if you were one of those people who was fortunate enough to get AstraZeneca first and Pfizer or Moderna second, you won the race, won the contest. That's actually a really good thing to do. And this has been replicated in other studies that have been published from European countries, which did the same thing that Canada did, which allowed for heterologous vaccination. So I want to talk a little bit about breakthrough infections and transmission immunity. One of my favorite little editorial cartoons here, the 4 horsemen of the apocalypse, joined by a 5th horseman whose title is misinformation, which has been a real problem in the pandemic. So one of the things we hear a lot about is people who are fully vaccinated are ending up in hospital. Well, that must mean vaccines don't work. That's actually not what it means at all. And this is a nice little graphic. I'm going to turn it, the motion on in a second. It looks at the percentage of people vaccinated. So this is going to rise from 0 up to 100%. And I want you to watch what happens with hospitalizations in general, hospitalizations of unvaccinated people, and then, of course, hospitalizations of vaccinated people, recognizing that once 100% of the population is immunized, then any hospitalizations are going to occur in vaccinated people. And those hospitalizations can be generated from lots of different reasons. So I just have to switch over my pointer here to start it. And then just watch this, watch the vaccination rate go up, watch the rate of increase in hospitalizations of vaccinated people and unvaccinated people. But what you can see is as we vaccinate the population, hospitalizations drop off precipitously. And we're now up at 80. And in fact, compared to where we started, that's a dramatic drop. And then here we are at, if you look at 100%, it's already started going back. Sorry about that. 100% of vaccinations, basically, once all the population is vaccinated, the hospitalizations are going to occur in vaccinated individuals. So be very careful how you look at that. I seem to have launched it again. There we go. Now I want to talk a little bit about the vaccine effect on transmission, because this is really important as well. So one of the things we know when we look at this study, it was a preprint, but I think it's now been accepted. This is comparing people who have become COVID infected but are fully vaccinated to people who are unvaccinated. And what you can see here along the x-axis, which is time, is that although they all start off with a similar value of how much virus is present, you can see that those that are fully vaccinated drop off very quickly and much quicker than people who are unvaccinated. And that tells us that that decline is really important, because once that viral load starts to decline, it may decline to the point where that person is no longer able to transmit. So that shorter duration of viral shedding is really important. The other thing we've seen is that when you compare people who are unvaccinated, here in this dark blue line, to vaccinated individuals, at any given viral load, which is measured along the x-axis here, the amount of virus that's actually infectious is markedly diminished. So if you take someone with a viral load here of about 6.3, if they're vaccinated, the amount of infectious virus they have is considerably lower than that in an unvaccinated individual. So this also tells us that vaccine has an effect on the infectiousness of the virions, and probably due to some binding by antibodies that may be present in the nasopharynx that make that virus less infectious. So vaccine has enormous benefits, shorter duration, and the virus itself seems to be less infectious. This is nicely demonstrated in a recent report of a children's indoor sport outbreak in Peel, just north and west of Toronto, back in August. And what they looked at was some involvement of sports teams, and then transmissible individuals, some of whom were under age 12 and therefore unvaccinated, and some over the age of 12. But what's really interesting here is that when there were secondary household contacts of cases that appeared in some of the children from different teams, all the people who were fully vaccinated never got infected. So that's telling you an enormously important thing of protecting you from being infected with COVID if you're fully vaccinated. So again, huge numbers of benefits to vaccination against COVID-19. So I'm going to wind it up now and just talk a little bit about what's the fall of 2021 going to look like. And I've talked a lot about, is it going to be a tsunami like we saw with wave 3? Is it going to be a rogue wave, so a rise, but not too big a rise? Or are we just going to face high tide? And that's really the question. So we do know from models, and this is a model that came out of a group in the States that looked at these what are called non-pharmaceutical interventions. Think of them as public health restrictions. And what they did is they modeled out with vaccine distribution, if you assume different efficacy and different coverage of vaccines, how does that work when non-pharmaceutical interventions are removed, which you can see here in dotted lines, or they're maintained? And in all circumstances, maintaining public health restrictions along with vaccine rollout, even if vaccine rollout was not particularly, large amounts of coverage or efficacy, you would have continued to see a decline in cases. Of course, what the Americans unfortunately did in many states is they removed public health restrictions, and that's why they've seen this huge jump in cases, which could be nicely demonstrated in these dotted lines. So what it means is that if you're looking at the Delta variant, using vaccines only, or using public health measures only. So this is really kind of like the United States. This is kind of like Australia and New Zealand. You are never going to defeat Delta. But if you combine both together, vaccines and public health measures, in fact, you can drop that reproductive number. It's very low and control cases. And this is just to sort of show you the difference between a Delta variant with a reproductive number of 6 and the original strain, which had a reproductive number of about 3. With the original strain, either vaccines alone or public health measures alone are very effective. But Delta's really changed that game, and we need both of those. And that's really why provinces like Ontario, to some degree in Quebec, who have maintained public health measures and good vaccination practices, are having a better time controlling numbers than in some provinces here in Canada where public health measures were abandoned during the summer. And this is actually what you can do. This is a nice example of Manitoba. So Manitoba was modeling out where things were going to go with these dotted lines here. Basically what they did is they went and brought in public health measures to increase vaccination. And what you can see here with this purple line is the actual cases. So when you had public health measures and vaccination, you never saw these model lines with a marked increase in cases. And Manitoba right now is doing a reasonably good job of controlling things with those two measures. So what's Ontario going to look like? Well, this is the modeling that was just produced by the Science Table. I was going to show you this on Monday when we originally recorded this, but I can now do it with great faith because it's been publicly released. And this really is looking at where we are now and taking into account a consortium of modelers around the province from Toronto, McMaster, Western, and New York. We can sort of paint 3 scenarios. This is the worst case scenario. This is where there's an increase, 25% increase in transmission. Here's a 25% decrease in transmission, which would be great. This is sort of status quo of where we are now. And in my view, in my opinion, that's where this part here, this is me editorializing it. This is where we're likely to be. And if we can really not just maintain status quo, but continue to restrict some of our social contacts, et cetera, then we are going to be in a good state and control these numbers. You can also see it with this, which was released by the Science Table as well, which looks at ICU occupancy in London Middlesex County here in Ontario, which has a population of 1 million people. And if we have 80% of our pre-pandemic contacts maintained, they will see a surge in cases there, and ours would be the same. But if we can keep it just 10% less, down to 70% of pre-pandemic contacts, in fact, we will have a nice leveling and an ability to control the numbers that are going to end up in intensive care and require that sort of high level of medical care. So I'm going to finish off just with a quick reminder to people that you need to be very careful nowadays when you're comparing COVID-19 waves with other countries, because they're not as applicable to Canada. In the United States, their vaccination rate is not as good as ours. And of course, many states abandoned public health measures. In the United Kingdom, they're pretty good, although they still weren't as good as we are here in Ontario and Canada. And they reduced some public health measures, but they're probably about as close as we could get, save a country like Denmark. In Australia, their vaccination rate's been very low, but they maintain strong public health measures. But again, you can't look at them because they've had a very different circumstance. And although Israel has vaccination rates that are very similar to ours, they didn't vaccinate those under the age of 16, between 12 and 16, which we did. And they did start to relax their public health measures in the late winter, early spring, and of course, saw a resurgence. They also vaccinated people very early. They had early supply of vaccine, and they used a shorter interval. And now they're finding out that that longer interval, as I showed you the data, is probably better. So when we look at the transmission reduction tools we have in place, I've put arrows here to emphasize my sort of view of how all these work. And it's important to recognize that there's lots of things we do that prevent the virus here from infecting someone here. This is a graphic that my colleague Ian Mackey in Australia came up with. And basically, you got to line up all these holes to have it effective. And there's lots of things you can do, physical distancing and masks, which are very effective. You should still wash your hands a lot, but fomite transmission of this virus only accounts for maybe about 10 to some 15% of cases. If you're in a crowded space, limit your time. Testing and tracing works well. Ventilation is important, but it's not the most important thing that you can do. It's one of many things you can do. And if you go down the line here, what you find out is vaccines are really number one. Lockdowns work, but nobody likes a lockdown. Border controls are very highly specific related to how you're controlling things in. So in my view, vaccines are number one. Number 2 and 3 are the things that we're continuing to do in public health, which is physical distancing and masks. And then some of these other things which you can do are important. But you know, as long as you're doing a few of these, you're not necessarily doing them all, you're going to have a reduction in transmission occurring, which is really going to be the effective way that we have to reduce overall cases here in Canada. So summing up, where are we now and where are we going? Well, we're in a fourth wave, but it's somewhat muted. The fourth wave arose because of the Delta variant and some reduced public health measures. And of course, still 1 in 5 of us here in Ontario are unvaccinated, and a large percentage are children who are not eligible at the moment for vaccine. Variants of interest have arisen, but none of them have been able to outcompete Delta. So Delta is our big problem, and I'm not worried at the moment that we're likely to see an immune escape variant. Vaccines are very effective against all variants, including Delta, and our best chance to flatten the fourth wave is to get all vaccinated and maintain public health measures as much as possible, and that will control cases. So my bottom line is get vaccinated if you aren't, and if you've had one shot, get your second shot. Terribly, terribly important. So I'm going to stop at that point. I'll stop my screen sharing and turn it back over to Mary Beth.
Thank you, Dr. Evans. That was very, very interesting. I really appreciated all that information. And just know for myself, it actually makes me feel a bit more confident and a little bit more hopeful about where we are right now. So thank you. I just have a few questions that have come up from our town hall chat. And one is there any scientific support for the argument that if you have had COVID-19 already, that you don't need to get vaccinated?
Great question, and it's a common question that I think a lot of us have been asked. So interestingly enough, vaccine-induced immunity to COVID-19 is actually superior to natural immunity. And this is somewhat counter to a lot of prior thinking. I go back to the measles example. People who had natural measles don't seem to need, follow-up measles vaccines like we do with most people nowadays who don't get measles. And that's because it's a different virus, but indeed, natural immunity to measles is superior to vaccine-induced immunity. But coronaviruses, and in particular SARS-CoV-2, is very, very different. The immune response you get from natural infection is a little bit too heterogeneous. It invokes too many different arms in a non-specific way in the immune system, whereas the vaccines, which offer the spike protein in its pure form, seem to induce a much more vigorous response, both from T cells and B cells in terms of producing antibodies and cellular immunity, and through a thing called somatic hypermutation, actually create antibodies which can even deal with some of the variants, which is probably why we're seeing the vaccines work against variants. So if you've had COVID, we still recommend that you be vaccinated. You should get at least 1, if not 2 shots after that, because that vaccine-induced immunity is superior to what we see with natural immunity from COVID-19.
So what about the third shot? I know some groups are receiving the third shot now in Ontario, but if you've had 2 doses for AstraZeneca, for example, would your third shot be another dose of AstraZeneca, or would it be an mRNA vaccine? Or what are your thoughts about the third shot?
Right. So right now, at least, all we're using in Canada are the mRNA vaccines. Although AstraZeneca and Johnson & Johnson have both been approved, they're not actually being utilized in Canada. So if you're going to get a third booster shot, and that is recommended in specific groups who are known to have issues with immunity from vaccines, so transplant recipients, patients who are undergoing active chemotherapy for cancer, those with hematological malignancies, et cetera, they're all now eligible for boosters. One of the great things about the Canadian strategy is we went with this longer interval for a large percentage of the population. And if you've had that longer interval, the applicability of the data that's come out of Israel, where people got the shorter interval, or even the United States, where many people got a 3 or 4 week interval, is actually less applicable. And I showed you the data about the antibody levels you get with a longer interval. So at the moment, the NACI has recommended that there be specific groups, as I just mentioned, who should get a third booster. And especially if you got your initial full vaccination series very, very early, back in, say, January or February, and you had a short interval, no question that those boosters would be important in those groups. I think for everyone else, I would wait and sort of see. There's lots and lots of data from studies of human coronaviruses in the past, much of which has been somewhat ignored during this pandemic, to show that actually coronavirus protective immunity lasts for quite a while. It can probably go on for years, if not decades. But, you know, we're going to know a lot more about boosters in the future. And at the moment, if you've had a longer interval with the 2 mRNA vaccines, you're okay. The one question you asked is, what do you do if you had double AstraZeneca and if you're going to get a booster, you're going to get Pfizer or Moderna? And I certainly had a number of people reach out to me to say, I got AstraZeneca, both shots. How can I get the mRNA vaccines? And we're kind of working on that at the moment to figure out how that would work in our system. I don't run the vaccine system. Not that I really wish I did, but in essence, we have to sort of sort out all the intricacies of that, because we do want to boost some people. We still want to vaccinate people who are unvaccinated. That's incredibly important. But we will come up with a way to sort of deal with it. And not the least of which, I'll finish off by saying lots of people want to travel. And the Americans have been a little bit kind of antsy about if you got AstraZeneca double dose versus Pfizer or Moderna, which probably represents a small degree of vaccine nationalism, if I could say that. So we're still trying to sort those kinds of things out. But I would tell everyone to stay tuned, and as that begins to roll out, that should help.
And finally, where is the best source for finding evidence-based, reliable information on COVID-19 and vaccination?
Well, certainly one place you can start off with, it can be a little bit on the deep side, is the Ontario Science Table. We have a website where our briefs are published, and you can download them and read them. We have a dashboard, and I showed people some of the graphics that we have in our dashboard, which can be very useful to sort of looking at where things are now. So those are that would be, I mean, pitching it as a member of the Science Table, but really it's the work of my colleagues. I'm one of about 35 members on the Science Table. So that's a very good source of information. It's very specific. Other than that, I would just express a certain degree of concern about going to social media. As a guy who's on Twitter, and I do tweet out things about COVID, not infrequently, the information there, even from people who have a very strong following or very adept individuals, oftentimes can be biased by the sort of inherent view that you have of things. And a lot of us, even though we try not to have confirmation bias in our thinking, and we sometimes tweet about things perhaps that we have a strong feeling about, but may not necessarily be true because we're looking at it through a very specific lens. Other than that, there's a lot of medical literature out there, but most of that stuff is pretty dense and can be hard to sort of tease out as you go through it. So I guess my big pitch is the Science Table here in Ontario is probably a good place to get some reasonably objective information from. And, I guess otherwise, read everything on social media and in the media with a bit of a jaded eye. My handle on Twitter is skeptical ID doc, so always look at everything with a little bit of skepticism until you've had a chance to kind of vet it with various individuals.
Thank you very much, Dr. Evans. I also want to mention that you've been very gracious in allowing us to have a copy of your slides available, and we'll have those up on the principal's website. We really appreciate you taking the time twice to share this information with us for the town hall today. Thanks very much. And now to Principal Deane. You shared at the beginning that there were some very high vaccination rates, and that's very great to see amongst our Queen's community. But can you emphasize why it's so important to mandate the remaining 1% who's not yet been vaccinated to get the shot? The person that asked this question said that it seems like a lot of resources have been directed to this very small percentage of people.
Well, that is certainly true. That small percentage does require a lot of attention. I think the answer to that question is in Dr. Evans's presentation. I mean, it's quite clear that if our goal is to make the community as safe as possible and to do our business in person as we wish to do, we have to take every step possible to make sure that people are as safe as it can be. And it was clear from Dr. Evans's presentation that there is no more effective method of controlling the spread of the virus than vaccination when taken in conjunction with the various public health measures. So if you look at the way the universities approach the question, you can see our emphasis is on both the mandate for vaccination, but also we're continuing to rigorously observe public health measures, all in the interest of keeping this whole community safe and all the communities that intersect with it through the members of the Queen's community.
So why have we decided to enforce mandatory vaccinations? So can we not give any other measures such as rapid testing, or can we accommodate the community members who've chosen not to get vaccinated for various reasons?
Well, I think, there are two ways of approaching that question. One is you can tell by the recent government actions on this issue and the declarations from the Chief Medical Officer of Health for Ontario that it is the view of medical professionals that vaccination mandates are desirable and important in institutions like ours. So there is that. The other side of the question, of course, is that once again, we're back at the issue of maximizing the safety of the community. And clearly to have individuals vaccinated rather than unvaccinated and being subjected to frequent testing these are not equivalent things. The safer measure is vaccination. And the wisdom of researchers is that the regular testing regime isn't nearly as effective in achieving that goal.
And can you clarify what's going to happen with staff, students, and faculty who haven't declared a vaccination status or who've said that they won't be fully vaccinated by October 15th?
This is, of course, the critical question. I'd preface it by saying all of the measures we're taking are intended to benefit our community and to enable the members of our community to do their work and to do so happily and safely. So obviously, it would run counter to that to seek to enforce these measures with draconian rigor and stringency. On the other hand, it's very important that we do enforce the vaccination mandate for the good I described earlier on. So bearing all of those things in mind, we're giving people as much latitude as we can to think about the advantages of vaccination, to educate themselves or to be educated by others in the science of vaccination. And then if people still choose not to be vaccinated and do not have the appropriate justifications for exemption, then it depends on the constituency and the university, but the basic strategy is the same, to require them to take a break. They cannot come onto campus. And then over a period of time, if their being on campus is essential to their doing their job, that obviously may lead to some significant issues to be addressed in the future. But overall, our strategy is that we want people to comply. We want it not to be an issue, and we don't want to see it lead to either, in the case of students, withdrawal from program, or in the case of employees, termination.
And one last question. We have a question regarding the student parties that we've been seeing around town that certainly go against COVID public health protocols. So while we're hearing that these students are receiving fines, we've heard nothing about any discipline through the non-academic misconduct process. So what is being done, if anything, to not only impact these students monetarily, but academically?
I think the important point to make before I answer that question is that some of these behavioral problems involve a minority of the students. The majority of our students have worked very hard to be cooperative and thoughtful members of this community and properly cautious given the health challenges. I'd also say that the student leadership has worked very hard with the university to address these street parties. And while our focus is on students who are engaging in behavior that runs counter to public expectations at the moment, the majority are very much in support of our overall goals of keeping the community safe. So we do have, as we have at different times, we have an arrangement with the city and with the police so that the identities of students who are either served with tickets or other kinds of notices of infraction are transferred to the university, and we can take action if it is appropriate against those students under the code of conduct. The important thing about this is, indeed, yes, names are flowing from those authorities to the university, but we do have a process. I know there is an appetite in the community for summary expulsions and such things, but the university doesn't work that way. If a student is going to be subject to discipline, there is a process which has to be employed, which includes the right of the student to defend themselves and the university to investigate the situation. So that takes time. So we are in the early weeks of term, and the information is flowing to the university, and action will be taken against the students as appropriate in the weeks to come.
Thank you very much, Patrick. So now we're going to turn to Mark Green, Provost and Vice Principal Academic, for a few questions. So first of all, do you have any information about the number of new cases in faculty, staff, and students that we've seen since the beginning of this fall term?
I truly understand how important this question is for people to feel safe on campus. And I'm happy to confirm that yes, we have a case tracker on the Safe Return website that tracks all cases within the Queen's community. And that web page is updated on a daily basis. And while a few individuals in the Queen's community have contracted COVID-19 this fall, Public Health has confirmed that there has been no transmission within campus activities. So we're very encouraged by that. Thank you.
Great, so there's been no kind of further exposure to people within the classroom. And have any courses had to go remote at all because of exposures?
Yes, that is true. That the classroom environment has been shown to be very safe, and that the measures that have been instituted with the vaccination mandates, et cetera, has provided that appropriate safety measures, as Dr. Evans so eloquently demonstrated to us earlier. I can confirm that case investigation and contact management is managed through the KFLNA Public Health Unit, and they have not found any evidence of transmission on campus. There have been some instances where individuals have attended class during the their infectious period before they were aware that they had COVID-19. But Public Health has not identified any further transmission as a result of those cases. And I can assure that individuals who were potentially either high or low risk contacts, i.e. other students and the instructor in the class, were all contacted to be informed of the potential exposure, and with recommendations as appropriate for follow-up monitoring and testing. And furthermore, that public health has not recommended in any cases that we move any of our classes to remote learning as a result of any cases that have been present on or on campus. And also the Central University has not made that recommendation out of those protocols. And all of this is because of all the very high vaccination rates, and Dr. Evans mentioned about how that's so critically important, but also all the other measures such as the contact tracing that is done by public health, as well as the mandatory mask use and the daily screening. And those are really important and effective measures. Encourage everyone to stay home if feeling sick, and particularly if there are symptoms that are specifically associated with COVID-19. And all of these, when combined together, keep our community safe. So thank you very much.
And Mark, there seems to be some confusion about which activities beyond classes are allowed to happen in person on campus without social distancing. So can you clarify that for us?
Thank you once again for this. And I truly understand that the rules can be challenging to understand and to understand the rationales behind them. And so I can confirm that in line with the government regulations in step 3, that physical distancing is required in non-instructional spaces on campus. So in eating areas, common areas, etc. However, because of the critical importance of education to society and the well-being of students, staff, and faculty, combined with the strong vaccination mandates that we have on campus, the Chief Medical Officer of Health, Dr. Kieran Moore, has strongly recommended that the post-secondary institutions be able to remove the physical distancing and capacity limits for those instructional spaces so that that learning can continue. Similar approaches have also been effectively taken in other provinces in Canada. And the government agreed in late August with Dr. Moore's recommendation, and that has allowed us to remove the physical distancing in the classroom instructional settings. And there is an outline of the instructional spaces on the Safe Return website. Furthermore, we have event planning guidelines for the fall of 2020 that's also available on the Safe Return website, and people can get clear guidance for other types of activities. So once again, thanks for the question.
Mark, another question for you. What is the timeline and policy around hosting an in-person research workshop at Queen's or international research trips?
Yeah, thanks once again, Mary Beth. I know this is really important for so many of our researchers because so much research has been delayed during this time of COVID. So it is possible now to have small research workshops on campus. Just have to bear in mind that we do have physical distancing limitations for those, as well as not having food and drink in the same way that you would normally have, unless it's in a specialized dining hall, etc. With regard to international research trips, there are also processes for that. It would have to go through some special COVID processes similar to those that are in the off-campus safety policy. And so you can find it, because all international travel is higher risk now because of the COVID situation. So in summary, there are ways to facilitate those important activities, but we're not quite back to the normal practice that we were pre-pandemic. Thanks.
Thanks very much, Mark. Now I'd like to turn things to Dr. David Walker. We have a question from someone who's concerned that students aren't being tested on campus for COVID-19 and instead are being directed to either Beech Grove or the Napanee Testing Center. Can you confirm for us if this is true or not?
The responsibility for COVID assessment and testing is actually from the government of Ontario through Ontario Health. And in our region, that responsibility is downloaded to Kingston Health Sciences Centre. And we work closely with Kingston Health Sciences Centre to make sure the deployment of testing capability is carried out effectively and properly. As it stands with the numbers at the moment, the deployment of the staff necessary to do this, as determined by the hospital, is at the Beech Grove site. When numbers justify it, and as they did during previous waves, we of course had testing assessments on campus. But with the numbers currently in play, that would not be justifiable. If you look at our case tracker, no cases this week, 5 last week, 3 the week before, the hospital would not feel justified in providing that testing on campus in that setting. But we meet with them, Mark and I and others, on a regular basis and monitor the situation. I would say that a student who is unwell and presents at student wellness services may be tested as part of their assessment of their illness, just as if they were unwell and went to the hospital emergency department, they would be tested as well. But the current deployment seems to make sense with the resources that the hospital provides.
I'd now like to ask Donna Janiec, Vice Principal of Finance and Administration, a few questions. So we've had a number of questions regarding how we're addressing the mental health needs of staff and faculty. We know that many staff are reporting feeling burnt out and have also read about the Great Resignation, the trend that is seeing many workers, particularly Gen Z and millennial workers, leave their jobs. Others have said that this has appeared to be a very fast and forced return to work without much consideration for mental health. Some may not feel ready to work around people or are unsure of how healthy the work environment is. So besides resources like our EFAP program, what are we doing to help assist our employees with these issues and deal with the very real problem of burnout, overwork, and mental exhaustion?
Thank you very much for that question, Mary Beth. It's a real one, and I think we're all feeling it. So first of all, I want to say how important employee wellness is to the university. I mean, work-life balance is important, and over the last 18 months to 20 months, we've had a tough time. And so there is a lot of stress. You know, we totally understand the anxiety of all of our staff and students in coming back to campus. As we've said in the town hall and as information on our Safe Return website, we've done everything we can, you know, to try to make the campus as safe and healthy as possible. But we do understand the anxiety that this has caused with some of our staff coming back. So as a priority, if you go to the Human Resources website, you'll see under the Wellness and Accessibility tab, I believe, on the Human Resources website, lots of tools and resources around wellness, you know, mental health, nutrition, physical health, to try to help us deal with those issues. The other thing that the university has done is allow us to have flexibility, because we understand right now that we need that flexibility in returning to campus after 20 months in a different environment. And so we've put in place remote work arrangements for those where it's possible in doing their work under a flexible arrangement. So that information is on the Human Resources website as well. And I encourage everyone to talk to their managers, supervisors, you know, to figure out how we can help with that flexibility and how we can help reduce that anxiety. Hopefully a lot of the information that Dr. Evans gave us will help us understand that, you know, that there is some light coming out of the tunnel, but we totally get the anxiety and the burnout and are there to support all of our employees.
Many staff, faculty, and students are parents of young children who cannot yet get vaccinated. So we have a question asking if there can be some consistency across campus on how to take time off when you're caring for young children who may be home from school or daycare if they're ill or have been sent home or isolating. Also, we know that it's largely women who've been negatively impacted because of this, as many take on the primary childcare duties. So what is Queen's doing to ensure equity and inclusion, given that women will continue to be needed to stay home to care for children who are sent home?
Yeah, it's a great question, and we don't know what the fall is going to be like for children at school. And so we continue to encourage flexibility across campus. I mean, we realize that everyone has to have, all employees, men or women, have to have that flexibility to be able to put in care arrangements for their children, deal with sick children. And so we encourage you to talk to your managers, talk to your co-workers, and we absolutely across the university understand that flexibility is required. We had that flexibility for the past 20 months and it will be required. So we are a very decentralized organization. So I encourage everyone, if you feel that you aren't being treated fairly in your current circumstances, to contact human resources. I mean, there is always that ability, but first of all, talk to your manager, and I'm sure that the flexibility that we've given you in the last 20 months will continue as we try to cope with the realities of trying to move back to the new normal.
And with so many people now returning to work on campus, it's brought another challenge, and that's parking. I understand that there are very long wait lists right now for parking on campus, and someone asked a question if there's any plans to offer additional parking spaces.
So, I did, when I saw that question, I did talk to parking to see what the situation was. And our waiting lists are actually less than what they were pre-pandemic. But there is a waiting list, which I was surprised about. But there are parking spaces available, and they're not as convenient. So there is a waiting list on main campus. There are parking permits available at 355 King Street, which is the old St. Mary's of the Lake property, and at West Campus. Recognizing that that's not very convenient, I encourage you to keep checking, because what happens in September, there's always a peak with students getting parking permits as well. And some of those drop off as they take the cars back home after they've been here for a little while. And so I encourage employees to keep checking back with parking to see if permit spaces are available, but it's less. The waiting list is less than it was pre-pandemic, which makes sense to me because not everybody has come back to work.
We have a question about ventilation. So one person in the town hall said that in their lecture room, they can achieve ventilation by opening the windows, and they're open all the time. But now it's starting to get cold. So what is being planned for buildings like that to balance the need for ventilation with temperature control?
So if there was no ventilation in the building, air purification units or HEPA filters were put in place in all of the classrooms where there was no ventilation. So I understand opening the windows to ensure that there's more airflow than the HEPA units can give, but there really is no need now to open the windows. We put those air purification units into those classrooms so that there would be no need to open the windows when it got colder. So if anyone has any concerns about a classroom that they're teaching in or studying in or a lab, please call the Fix-It desk because they will definitely look at it. So I'm not sure if those windows are open because no one can reach them to close them, but we will make sure to address those issues if we're told about them, and just call the Fix-It desk.
Thank you. That's really good to know. Just one last question, just to clarify, the vaccination stats that Principal Deane mentioned at the beginning of the town hall are among those that have completed the reporting process. So can you tell us what percentage of the Queen's community has not self-reported yet?
So right now, it's an excellent question, and it's always that last little bit in terms of the data. So right now, based on our record, the student records and our employee records, about 95% of people have self-reported, have filled in the declaration. That last 5% we're trying to get to the bottom of. Many of, say, the students are those that are in programs where they never access campus, distance study programs or so on. And so we're trying to get to the bottom of that because they're not on campus and they probably don't see any reason for them doing the self-declaration. And the same thing is for the employees. We have a number of adjunct ones, emeritus professors, casual staff that aren't being paid right now, but they're in our payroll system and they're not paid, but they're in our system, and they're making up the bulk of those employees that have not yet filled in the forms, but they're not accessing campus. So we're trying to address that delta, and it's time consuming, but we believe that if not all, but the majority of those individuals that have not self-declared, it's because they have no intention of being on campus.
Thank you for clarifying that. I appreciate that. Principal Deane, would you like to give a few closing remarks?
Yeah, thanks, Mary Beth. First of all, I want to thank everybody for watching this recording and for attending the live stream earlier in the week, so long as it lasted. To thank you for being engaged with these issues and for raising the questions you have. This is a very challenging time for the university, and it has been. We've been through 20 months of challenges. And as I said at the start, the return to in-person life on campus is challenging in ways that the move to remote was not. But I do feel we're making progress. I'm really grateful to everyone for their cooperation and commitment to ensuring that we get through this in the safest possible way. And thanks to all my colleagues for being on the call and answering all the questions as well as they've done. So my word to everybody on the call is persist, keep up the extraordinarily good work. We will get through this, and the institution will enjoy better times in the future. Thanks very much.
Thank you very much, Patrick. Don't forget, the Safe Return website has a lot of information that can help all of us as we navigate our safe return to campus over the fall term. I'd now like to welcome back Nathan Brinklow, who will offer a traditional close to our town hall meeting. And thank you all very much for tuning into this broadcast. Nathan?
What's going on, Are? Greetings to all again. As we gather once again to conclude our time together in this virtual space, we bring our minds together to send our greetings to all of the elements of the natural world that continue to work together for good. And as I promised when we opened this event, I will conclude in Ganyakeha or Mohawk. As you listen, you can follow along in your own mind with the things you are thankful for. I'll be starting with the people and then move upwards from the earth to the water, to the sky and beyond. So as you listen, you can call those things to your own mind. Ganjokwa, zewadonsios ne got negari wesa. Ne gadi don yetinu horadunha gate signore aguego no hoda what the hiardos, gundiches, wadawans, gundizerles, de dawanies, la didakes, ne owange o honzage deno garhunyake. Aguego oscadzi under the wahwet nuni ne guatniguna, dano datinu horado ne aguego ne unwet sua, gisego yungwayo dache anaidun hioage, toganyo dohak ne no guatniguna. Dano oni datinu horado ni yetinistaha, zio honzade, gisego jagotka 100 na gosatstansra naidun hioage, toganyo dohak neoduhak ne no guatniguna. Aguego oscadzi under the wahwet nuni ne guatniguna, dano datinu horado ne gahne garunyu, dano aguego owange tadidra. Toganyo dohak ne no guatniguna. Aguego oscadzi under the wahwet nuni ne guatniguna, dano datinu horado no hoda ne yuntun ni hadje. Ne o honzage. Ne o dera sua, ne hunde sua, ne gahik sua, ne onukwa sua, Ne jo hekwa dana garunda sua dana ogre sua. Toga ni odo hakne no gwani gona. Dana oni ne eno date no cordados in hodne what yards. No ti no sua dana gario da sua ji sego de wat gatunios radidakes ovanzage. Toga ni odo hakne no gwani gona. Ena gonna gadi don't ci do wadet ni goradi honto dana date no cordados in your aguego ne lo di sastan saraya. Ne gaieri ni gawarage. Ne yuki soto gun already wera sana garakwa sua ne ti do wazia ne yeti sota dan ne yo just okwarunyo ji sego to wat cartoons to gani to hakne no gani gorna dan agwego oscar ti under do wet nuni ne gwani gorna dan de chi no pardado ne son kwa disa ne gasa stant sarawana sa yera da u ni sir dat ne date no pardado no nga huwa ne ha so agwego o huwa der hona der yonder age ji sego yung guardar nung go ci sego de guardar nung go wana ci sego yung guardi washers nung guardi holders dan sego de no guardado agwego ne yung wana toga yo do hakne no gwani gona ona tony ore wakaderi wat gwani doga tano ni isun get ni go easy get ne a wali as what the sondra took ne ni go one wakeri wan hodungo dan skona ze wat nun se wat nun se wan nun dun you hak yawa